Good morning, everyone. Uh, Today we are going to learn about the rest of the classes of the drugs which are used in treatment of arrhythmia. So let's start with it. We have studied everything about the arrhythmia. Then also we have studied the types of arrhythmia, then causes of arrhythmia, then what is the abnormal automaticity, then what is the abnormalities in impulse conduction, and also we have started with the anti-arrhythmic drugs and what are the objectives of the uh, anti-arrhythmic drugs. Okay, so treatment objectives we have studied. So we have studied the classification. In that we have finished with the class 1 anti-arrhythmic drugs. Thereunder there are three subclasses, that is class 1A, class 1B and class 1C. So today we are going to start with the class 2, then we'll proceed with class 3 and class 4. Okay, so this all we have covered till now. I will just move to the slide where I have included information about class 2 anti-arrhythmia. Okay, so I'll just take up the pen. Okay, I will select the pen. Okay, fine. So class 2 agents, what they are, as we have studied the class 1 agents, they are all the sodium channel blockers, but the way they associate with the sodium channel and they dissociate with the sodium channel, that velocity of it or the action for the duration for which it remains over there, it only changes. Okay, and depending on that, it will have the multiple effects on the phase 0 of the rapid depolarization or the phase 4. Okay, so it affects the stiffness of that particular phase 4. Okay, so class 2 antiarrhythmic drugs, they are nothing but the beta adrenergic antagonist or the beta blockers. So we have studied in detail about these beta blockers in earlier chapters, but the application of these drugs in those particular diseases was different. Here it has different application. Okay, so what these drugs do? These drugs, they diminish phase 4 depolarization. Okay, and hence by diminishing phase 4 depolarization, it depresses the automaticity. So the abnormality of automaticity is rectified. Also they prolong the AV conduction, that is the flow of action potential through the AV node is delayed, and also it decreases the heart rate, so which is its common action as a beta blocker, and also it reduces the contractility. Okay, so these drugs, they are used or they are useful in treatment of the tachyarrhythmias. Okay, as I have said, when the prefix comes as tachy, it is like increase. Okay, it indicates increase in the rhythms. Okay, so with this tachyarrhythmias, which is caused due to the increased sympathetic activity, it is being reduced by these class 2 agents. Okay, they are also used for atrial flutter and fibrillation, and also for the AV nodal reentrant tachycardia. Okay, so this AV nodal reentrant tachycardia, its use in this condition, it is basically uh, attributed to its effect on this. That is, it prolongs AV conduction, and as it prolongs AV conduction, that's why it can be used in AV nodal reentrant tachycardia. Also, these beta blockers, they prevent life-threatening ventricular arrhythmias, which is following a myocardial infarction. Okay, so these are all the conditions in which these beta blockers, they find their use. Okay, so we have when we say beta blockers, it should be very clear that all of the drugs which are included under this class, they end up or their suffix is LOL. So the drugs which we have over here, it is metoprolol, and it is most widely used beta blocker for the treatment of cardiac arrhythmias. So when we compare it to the non-selective beta blocker, example of non-selective beta blocker is propranolol. Okay, so it reduces the risk of bronchospasm. So this propranolol, it has both blocker activity at beta 1 and beta 2 receptor. That's why propranolol suffers from the adverse effect of bronchospasm. That's why it is contraindicated in case of asthma. But that's not problem with selective beta blockers, as they selectively block only beta 1 receptor. They don't have any effect on the beta 2 receptor. That's why they can be utilized in case of the bronchial asthma also. Okay, so metoprolol, it is extensively metabolized by CYP2D6, and also it has CNS penetration. But this CNS penetration is less than propranolol, but it is more than atenolol. Okay, so next drug is ismolol. It is very short and fast acting beta blocker and is used for the intravenous administration in acute arrhythmias. Okay, so as it is a fast acting, that's why it finds is its use in acute arrhythmias. Okay, so these acute arrhythmias which occur during surgery or emergency situations, in that cases we have to go for ismolol. Otherwise metoprolol is the drug of choice. Okay, so this ismolol is rapidly metabolized by esterases in red blood cells. Okay, so the metabolism is also different from that of metoprolol. Metoprolol, it metabolism happens in liver, but ismolol, the metabolism happens in the red blood cells by the enzyme that is esterase. As such, there is no pharmacokinetic drug interaction of this particular drug. The common adverse effect with beta blocker, they include the bradycardia. Also, they cause the hypotension, as well as they can cause the fatigue. Okay, we have now class 3 anti-arrhythmic drugs. Okay, so these class 3 anti-arrhythmic drugs, what is their mechanism of action? That they block potassium channels and thus diminish outward potassium current, which happens during the repolarization of the cardiac cells. Okay, so understand, so the first category of drugs, that is class 1 drugs, that is sodium channel blockers. So wherever in that particular cardiac action potential the sodium channel is involved, those phases they will be affected due to, okay. In second case, it is a beta blocker, so there is no really question of any channel which is getting blocked. It has a uh, it has a completely different action from the rest of the drugs. But the class 3 agents, as they block the potassium channels, wherever the potassium channels are involved in the generation or the repolarization of the cardiac muscle fiber, there it is going to affect. Okay, so it can be seen in this particular diagram only. The class 3 drugs, what they do, they prolong phase 3 repolarization and without altering phase 0. So there is no effect on phase 0, as the phase 0 depends on the sodium channels, but it instead affects the phase 3. Okay, so when there is no drug, you can see how the phase 3 happens. It happens rapidly. Okay, it is rapid repolarization. But when the potassium channel blockers they are given, it causes prolonging of the phase 3. So this effective refractory period, it increases. Always remember, the drugs which we give for the treatment of arrhythmia, they try to keep the cardiac muscles into the refractory period. And the refractory period, it is within which there can be no generation of another action potential. Okay, so what these drugs do, the class 3 agents, they prolong the duration of the action potential without altering phase 0 of depolarization or the resting membrane potential. Okay, so the class 1, they affect this phase 0 and the resting membrane potential, but this class 3, they don't have any action on this. Instead, it acts on the phase 3 and thus prolonging the effective refractory period. Okay, so as I said, they prolong the effective refractory period, thus increasing the refractoriness. Okay, all of the class 3 drugs, they have potential to induce arrhythmias. Okay, so that's why when we give the class 3 agents, we should be very careful about it. Okay, otherwise what will happen if we uh, don't observe the patient who is on class 3 agents? These class 3 agents will them by themselves will cause the arrhythmias. Okay, so they are the prorhythmics. Okay, so the first drug and the prototype of this class, that is the amiodarone. Okay, there are other drugs also, but we will study everything about amiodarone. Uh, that will be applicable to the other drugs also, but they will differ from the amiodarone in in case of the pharmacokinetics and the toxicity profile only. Otherwise, make of action will be the same. Okay, so mechanism of action of amiodarone. This drug contains iodine and is related structurally to the thyroxine. Okay, so it has complex effects showing class 1, class 2, class 3, and class 4 action, like that of the anti-arrhythmic drugs, as well as alpha blocking activity. So multiple activities it has. It will block the sodium channels also. It will have the beta blocker activity also. It will have the potassium channel blocking activity also. It will have calcium channel blocking activity also, as well as it will have the alpha blocking activity. Okay, it is quite complicated. Okay, so its dominant effect is prolongation of the action potential duration and the refractory period by blocking the potassium channel. Although it has all of these actions, but the most common or most dominant one is the class 3 action. Okay, that's why this drug is, we mainly classify it under the class 3. Okay, so the therapeutic uses of amiodarone, it has been mainstay of therapy for rhythm management of the atrial fibrillation or the flutter. Despite its adverse effect profile, amiodarone is thought to be the least prorhythmic of class 1 and class 3 anti-arrhythmic drugs. Okay, so it has very less propensity to cause the arrhythmia when we compare it to the other drugs from this same class, that is class 3, as well as the drugs from the class 1. Okay, so the amiodarone is effective in treatment of severe refractory supraventricular and ventricular tachyarrhythmias. Okay, so the pharmacokinetics, amiodarone is incompletely absorbed after oral administration. Okay, so the drug is unusual in having prolonged half-life of several weeks. This is very important, and it distributes extensively in the tissues. Okay, so the full clinical effects may not be achieved until months after initiation of treatment unless loading doses are employed. Okay, so with regular doses, as most of the dose will be distributed to the various tissues, that's why very less plasma concentration will be present, and this less plasma concentration, it is not sufficient to achieve the full anti-arrhythmic effect. That's why loading dose is essential for the amiodarone. Okay, so the adverse effects of the amiodarone, they include, they shows variety of toxic effect, which include the pulmonary fibrosis, then neuropathy, then hepatotoxicity, then corneal deposits, then optic neuritis, then blue-gray skin discoloration, and the hypo or hyperthyroidism. Okay, so as it has the thyroxine like structure, that's why it causes hypo or hyperthyroidism. Okay, so use of low doses and close monitoring, it reduces the toxicity while retaining the clinical efficacy. Okay, so the amiodarone is subject to numerous drug interaction since it is metabolized by the major enzyme, that is CYP3A4, and it serves as inhibitor of CYP1A2, CYP2C9, CYP2D6, and the P glycoprotein. Okay, so as it is metabolized by this CYP3A4 enzyme, which is the enzyme that metabolizes like 70% of the prescription drug. That's why there are many other drugs that inhibit this enzyme. Okay, so if this enzyme is inhibited, if if suppose we have the amiodarone, okay, and we have another drug, let's assume it is B. Okay, so amiodarone, we know it gets metabolized in presence of C3A4, okay, to the metabolite, that is C. So if this drug, which is known inhibitor of this CYP3A4, if it is given with the amiodarone, then the conversion or the metabolism of the amiodarone, it will decrease. So that is, there is decrease in formation of C. So it implies that the amount of amiodarone in the body, it will increase, and thus it will produce the toxicity or the toxic effects. Okay, so that's why it is said that it is subject to numerous drug interactions. Okay, so now the last class of the drug, that is the class 4 anti-arrhythmic drugs. Okay, so these class 4 drugs are the non-dihydropyridine calcium channel blockers. Examples: verapamil and diltiazem. Why it is said that non-dihydropyridine? Because calcium channel blockers, as we have studied the classification also, there are three classes of it. Okay, so one of the class is dihydropyridine, and the example of the drug that comes under this class, it is amlodipine. Although the amlodipine is a calcium channel blocker, but it has no any role or no any efficacy in the arrhythmia. Okay, that's why it is said specifically that only non-dihydropyridine calcium channel blockers, they are used in the treatment of the arrhythmia. Okay, so although voltage sensitive calcium channels, they occur in many different tissues, the major effect of calcium channel blocker is on vascular smooth muscle and the heart. Okay, so both of these drugs, they show greater action on heart than vascular smooth muscle, but more so with the verapamil. Okay, so if we have to consider, or if we have to take one of the calcium channel blocker, then we have to choose the verapamil over the diltiazem, because it has more profound calcium channel blocking action on the heart rather than onto the vascular muscle. It is exactly opposite in case of the amlodipine. Amlodipine have more effect on the vascular smooth muscle rather than on the heart. That's why the dihydropyridines, they are not preferred in case of the anti-arrhythmic treatment. So what class 4 drugs do? They slow the phase 4 spontaneous depolarization, and also they slow conduction in the tissues which is dependent on calcium currents such as AV node. Okay, so AV nodes, the action potential generation, it is dependent on the calcium. So by blockade of the calcium channels, this particular conduction through the AV node, it is prevented. Okay, so the verapamil and the diltiazem, they block the open or inactivated calcium channels. Okay, so in the heart, verapamil and diltiazem, they bind only to open depolarized voltage sensitive channels, and thus they decrease inward current which is carried by the calcium. Okay, so thus these drugs are use dependent, just like that of the class 1 drugs. These drugs are also use dependent because they prevent repolarization until the drug dissociates from the channel, and thus results in decreased rate of the phase 4 spontaneous depolarization. Okay, so they also slow the conduction in tissues which are dependent on calcium currents such as AV node and SA node. Okay, so uh, unlike that of the other excitable cells, so which depend on the sodium influx for the depolarization to occur, these AV node and SA node, they are more dependent on the calcium channels. So if we block the calcium channels, inward calcium currents, then there will be decrease in the conduction or by the AV and SA node. Okay, so these agents, they are more effective against atrial than against ventricular arrhythmias. Okay, so they are useful in treating reentrant supraventricular tachycardia and also in reducing the ventricular rate in atrial flutter and the atrial fibrillation. Okay, so the common adverse effects of this drug, they include bradycardia, hypotension, and peripheral edema. Both of these drugs, they are metabolized in liver by the enzyme that is CYP3A4. Dosage adjustment may be needed in patients with hepatic dysfunction, which is actually this is applicable to like all of the drugs which we have mentioned till now, because almost all of the drugs, they undergo metabolism in liver. That's why in patients with hepatic dysfunction, we have to adjust the dose. Okay, so these drugs, they subject to many drug interaction as they are CYP3A4 inhibitors as well as substrates and inhibitors of the P glycoprotein. Okay, so that was all for the uh, class 4 anti-arrhythmic drugs, and with this we have finished with the chapter that is drugs used in the arrhythmia. There are other drugs also apart from this, but those drugs we have, some of those drugs we have already discussed, and if not discussed, you have to refer it from the book. Okay, so for this particular topic or any other topics, I have referred the book that is Lipincot's Pharmacology. Okay, so with this, I will conclude my lecture and I will stop. Thank you.